Right, welcome everyone. We'll make a start. So thank you for joining our next Glaucoma Support Group. We've got Mr Nick Strouthidis here from Moorfields Eye Hospital in London. He's going to be talking about the glaucoma journey and how coronavirus is changing eye care. My name's Joanna Bradley. I'm Head of Support Services here at Glaucoma UK. For those of you who don't know, we are the UK's only charity that helps people specifically with glaucoma. We do three, I'm just going to see if I can share my screen. We follow three areas of activity. So we campaign and run awareness campaigns for glaucoma, so people become aware of the condition and they get their eyes tested. We also provide help and support to people with glaucoma so they can live well with their condition. We do that through helping people directly, as well as working with clinicians, so doctors, eye doctors, optometrists, lots of other sort of groups that are helping people with glaucoma. We have an information services, a helpline, we've got free leaflets and support groups like these. And the other bit of activity that we do is fund research into glaucoma to help sort of identify the causes of glaucoma and look at better treatment options or ways to prevent it. So that's a very, very quick introduction to us. We've got a new website. We've recently rebranded. We were the International Glaucoma Association till quite recently. We've got a new website. The information you should be able to see on your screen. Check it out. Come and sort of have a look at the services that we have available. So that's us. I'm going to talk very quickly through some of the functionality within Zoom, so you know how to participate. There is a poll. I'm just about to launch the poll now. So that's just to see how much you know about glaucoma and about us as a charity, and how much you know about sort of today's topic. So if you can see that on your screens, you should be able to start voting in that now. I'll keep that open for about 10 minutes. We also have a Q&A, so if you want to ask any questions of Nick or myself during the talk, you type your questions into the Q&A section at the bottom, and you'll be able to see the other questions that people have asked. And if you like that question, you should be able to give it the thumbs up or comment on it as well. And we'll be able to see that so we can focus on the questions that are of particular interest to as many of you as possible. And if you find typing quite hard and you're sort of a bit of a slow typer and you would find it easier to ask your question live, sort of, you know, just by talking, then you can click the raise your hand button and someone will ask you if you want to, if you do want to ask a question, and then you can just type yes, and then we can unmute you at the kind of appropriate time, and then you can ask your question live. So that option is available if you find typing hard. If you're watching this on Facebook, because we're streaming this live to Facebook now, you can type your comments in, type any questions into the comments section on Facebook. And we've got Hannah behind the scenes who will transfer that into Zoom so we can still see your questions. So you can still take part even if you're watching via Facebook. So on that note, I'm going to hand over to Nick. So Nick, thank you very much for coming to talk, and over to you.
Right. Okay. Good evening, everyone. I hope you can all hear me. My name is Nick Strouthidis. I am a glaucoma specialist consultant based at Moorfields. I'm also trustee of Glaucoma UK. And I suppose the most relevant thing, other than my glaucoma background, to the topic we're about to speak about this evening, is that I'm the medical director of Moorfields Eye Hospital. So I've had a very central role in how our biggest eye hospital has coped with the pressures and changes in practice that we've had to put in place because of the uncertainties caused by the coronavirus pandemic. I'm not going to be using any slides, and I don't actually have a script today. I'm going to really just riff on my experiences of the last 5 months and hope that you can get a flavour of where the management of glaucoma for you as patients and people who support patients with glaucoma might expect in the coming weeks, months, and years in the aftermath of what's been going on. But before I talk about COVID and how it's affected the glaucoma pathway, I want us all to cast our mind back to 5-6 months ago, to perhaps January or February of this year. I'm sure, you know, we'll all like to think that the way our glaucoma clinics ran and the services that were being provided in our communities and in our hospitals to manage glaucoma were perfect, and that there were no long waits and there were no cancelled appointments. But of course, this is not true at all. I think it's fair to say that managing glaucoma, which is the second biggest cause of irreversible blindness in the UK, was extremely difficult. And the reason for that is that there are far more patients that need to be seen than can be reliably and safely seen in a timely fashion within the hospital ophthalmic services. So that there is a mismatch between demand and capacity. Now, the reason for this is that there are a large number of patients who are identified as having a risk of glaucoma or have early glaucoma. And there is a proportion of patients who have a significant risk of losing vision during their lifetime from glaucoma. But it's actually a relatively small percentage. But of course, because there's that risk to potentially to a large number of people, they all need to be seen and reviewed in a timely fashion. And literally 6 weeks before COVID was a known entity in the UK, there was an alert from an organisation called the HSIB. And this caused a lot of consternation in hospital ophthalmology, because it brought to light shortcomings in the hospital glaucoma services, triggered by a single case in the Southampton area where a young lady in her 30s went legally blind in both eyes, having had numerous appointments cancelled. And I think for many of you in around the country with glaucoma, the experience of having your appointment cancelled at the last minute is probably not an unusual one. And it is, you know, it is a sign of the fact that it's very hard to have enough members of staff to see the number of patients that need to be seen. But of course, it needs to be done in a way that ensures that patients at the highest risk of losing vision are not lost in the system. And unfortunately, in this particular case in the Southampton area, a patient who was quite young and was in fact was a new mother, managed to, you know, because of multiple cancelled appointments, lost a significant amount of vision in both eyes. And it really alerted the wider NHS to the risks of not being able to provide the right number of glaucoma appointments. So we have that background of this was the situation where glaucoma was in January. So depending on where you were in the UK, you may well have had a much more efficient and effective service, and you weren't getting cancelled appointments. You may have been in a situation where your glaucoma appointments were much quicker. You were in and out of the hospital in an hour. But you know, certainly in my hospital, which manages about 130,000 glaucoma outpatients per year, which is by some distance the largest glaucoma service in the UK. You know, patient waiting times in clinic were about 3 hours. And so in order to safely handle such a high volume of patients and not lose patients that are at risk of going blind, one has to find ways of new ways of managing patients, so that not every single patient needs to have you know, a sort of conventional face-to-face appointment with a consultant. So even in January, and in Moorfields much earlier on, you know, over the past 2 or 3 years, we have been looking at new pathways for managing our glaucoma patients, so that essentially we are creating pathways where the right patient is seen at the right time by the right person, essentially. So I'll leave that thought in your mind as to what we were trying to do pre-lockdown, and then introduce the sort of hand grenade that is the coronavirus pandemic. So I first became aware, like many of you, about COVID probably around about December time, when we became aware of what was happening in Wuhan. And for those of us in ophthalmology, we were quite, our interest was piqued, because the doctors that first identified the COVID, and the ones that were the whistleblowers and who were, silenced by the authorities allegedly in China, they were ophthalmologists. And in fact, the very first person, the first whistleblower who died, was a glaucoma specialist, and he had been managing the sort of first test case of COVID. It was a patient with angle closure glaucoma. So there was a particular resonance amongst ophthalmologists about COVID, and in that particular unit, I think of the 11 doctors that died, 3 of them were eye doctors. So for us as a ophthalmology community, there was a concern that we were, if this virus came over to the UK, that we would be at heightened risk. Now, of course, we knew about this in December, January time, but as with much of the UK's health system and the government, our the response to this has really been a little bit behind the 8 ball. So we could see what was happening in Italy, the terrible kind of lockdown that they had to endure, and whole generations of people being lost to the ravages of this virus. And we were starting to think, well, what's gonna happen if it comes to the UK? And in fact, one of the glaucoma professors at Moorfields in February sent myself and the chief executive of Moorfields an email, basically outlining everything that he thought should be done to manage reduction in infection. And every single thing that he described in terms of wearing face masks, single flow through the hospital, 2-meter distancing, perspex shield, segregation of the canteen, all of the things that when you go to the hospital you should be seeing, their temperature checks at the front door, etc., etc. He was saying that we need to do this, and we need to do this right now. But of course, at the time, the evidence for us and what we were hearing from Public Health England and from the government just wasn't there. But lo and behold, within a matter of weeks, we were getting there were the first cases that were coming through in England, and it became very clear as the doubling rate in ITU, so the number of admissions with COVID to ITU was doubling every few days. It became very, very clear that business as usual in the hospitals was not going to be able to continue for much longer. Now, in the most hospitals, so not everyone has their glaucoma managed in a specialist eye hospital like Moorfields, but in most other hospitals, the eye department is embedded in another in a general hospital. And of course, in a general hospital, where, if particularly in London, if they were having to deal with a large number of COVID admissions, what that meant is that, firstly, a lot of the estate that would have been used for eye care was given over to other parts of the hospital to accommodate the influx of very sick patients. Anesthetic machines that would have been used to anesthetize patients who are having eye care may have been used for ventilation purposes to support the ITU and high dependency units that were seeing a large number of patients. And the other thing that happened in general hospitals is, of course, doctors that were otherwise doing eye care were being redeployed to support other services around the hospital. So, at large teaching hospitals outside of Moorfields, I had consultant colleagues who were working on the proning teams at ITU, turning patients onto their front when they were on ITU who were affected by COVID. So, that really did diminish the ability for routine ophthalmic care to be managed in the hospital setting. The situation at Moorfields was slightly different because, of course, we don't have general hospital admissions. We are not a general hospital. We are only dealing with eye problems. But of course, we're dealing with 600,000 outpatient appointments a year, a large majority of which are over 70 years old. So patients who were perceived to be at a high risk of getting COVID. And the bulk of what we do at Moorfields is elective surgery and elective care. So it's not necessarily sight or life dependent that patients were coming to the hospital. So we had to make a decision very early on to restrict our services in order to prevent both our patients from unwittingly getting COVID by traveling to the hospital in the first place, and then coming to the hospital and coming into contact with other patients, and also to protect our own staff, so that staff were not, unnecessarily seeing patients who didn't need to be seen. So the first kind of phase of what we did, which actually was quite quick to enact, was from the 32 sites in which Moorfields operated, we went down to 7, and we were just managing emergency and urgent care essentially for all of London. So really only doing things that were going to be imminently sight or life saving treatments. And whilst that was a sort of sustainable model for the first 6 weeks of lockdown, it became very clear that the restrictions that were being put in place by government and by Public Health England, etc., were not getting less, they were becoming more. So the period by which we were being restricted in terms of what we could do at the hospital was being prolonged. And I will give you a frightening figure, but this resulted in the postponement of 200,000 outpatient appointments at Moorfields, of which probably about 75,000 were glaucoma outpatient appointments. Okay, now in order to safely postpone that number of patients, we had to go through a process whereby the doctors who managed the glaucoma would go through the clinic lists week by week and assess how high risk each individual patient was, to see whether, if you were to defer their appointment for another 4 months, another 6 months, another 9 months, whether it was safe to do so. So a doctor went through every single patient's record and assessed whether they needed to be seen right now or whether it could be pushed back. And you can see that a very, very large number of patients have been processed in this way. Now, I will bring you back to how bad things were pre-COVID, and I have a sort of epithet of describing the recovery from COVID as we don't want it to be a boomerang of disaster. So I normally, amongst medical colleagues, use a much more rude phraseology. But essentially, what we don't want is to have the boomerang, you throw it, and when it comes back, you don't want it to land exactly where you were before. So we do need to recover, but do we actually want to recover to the position we were in before? Or do we want to be in a position to exploit the fact that we have got to be innovative and find new ways of working in order to not just address the backlog of, probably in London, across London, probably 200,000 cancelled glaucoma appointments. How do we address that backlog and at the same time make a permanent adjustment to what we are doing so that our patients are not at risk of losing their vision through cancelled appointments further down the track, that they're not sitting in outpatient appointments for 3-4 hours at a time, particularly in an era where sitting in an outpatient, however socially distanced, continues to put them at risk of virus transfer. So that is the challenge we now face: is how are we going to get through such a large number of deferred appointments, and at the same time, how are we going to make things better so that the improvements we put in stick? So this is where we are at now. So many of you will be aware of the concept of a virtual clinic. So a virtual clinic essentially means it is a visit to have your glaucoma assessed, where you come in, and it may be in the hospital, it may be outside of the hospital, but you have your diagnostic tests done, so your pressure, visual field, and an image of the optic disc taken most usually with an OCT, and some kind of brief history taking. And then the results of those tests are stored and then viewed remotely by the appropriate clinician. In Moorfields, that would be a consultant. A decision is then made about whether or not you're stable or whether you need a change to your management, and then a decision is made. Now, pre-COVID, Moorfields was probably the biggest user of this type of clinic. And of our 130,000 outpatient appointments in glaucoma, we were seeing approximately 15% of our outpatient appointments in this way. And that was working very, very well. But of course, we were still seeing a large number of patients face to face. And if we were to try and get through the backlog of patients that we have acquired through the lockdown, using the capacity we had for virtual and what were the conventional face-to-face clinic visits, it would take us 2 years to see all the patients. And that's not including the referrals that we get on top of that, which are about 8,000 new referrals a year. So clearly we have to do something to address that. And what we anticipate at Moorfields is that in order to get through the backlog, we would have to increase our number of patients seen in this way, so through a virtual clinic, from 15% to 70%. So really, really a staggering ramp up in that number of patients. But essentially, it would be just a one visit virtual clinic, because the time has the time has passed so long for some of these patients since their last appointment that what we want to do is bring them in and do a sense check of whether or not there's been any deterioration. So bring them in, get the tests done, and then we can quickly and rapidly and safely assess whether or not there's any urgent need for an individual patient to have a face-to-face appointment, rather than bringing all patients in for face-to-face appointments, which will take, as I've described, anything up to 2 years to do. So we are trying to get through, increase our virtual capacity by 70%. There will, of course, be patients who clearly cannot be seen in this way. There are patients who, for whatever reason, whether it's mobility, ability to do the various tests, etc., just cannot be seen, or their disease is so complex that they cannot be seen in this way. But of course, for the vast majority of patients who have relatively simple and relatively low risk glaucoma, this is a very tried and tested method of reviewing them. But in truth, to see this number of patients, we don't actually, if we were going to do it as virtual clinics, we don't actually have the space, the diagnostic equipment, or necessarily the staff in order to do this at Moorfields. So this has triggered the pursuit of something called a diagnostic hub. So the great plan that we are trying to get traction with NHS London and with charitable support as well, is to try and create a very, very large COVID-safe mega clinic with lots of lanes where testing can be done in order to process large numbers of patients who are at low risk of losing vision from glaucoma in a safe environment where we can get through a large number of patients without them necessarily needing to come into hospital. And so we haven't yet got to a point where we've been able to fund this. We are having to sort of scrimp and save and create mini diagnostic hubs within our existing hospital estate. But what we ultimately want to be able to do, at least at Moorfields, but also in other regions of London, and probably, we hope in large other metropolitan areas of the UK, is to create diagnostic hubs where the largest proportion of ophthalmic care, so specifically medical retina and glaucoma, the more routine care can be channeled through this environment in a COVID safe environment. But this is going to take a bit of time, and it's going to take an awful lot of money. I think the other thing that will be a concern to some glaucoma patients when I talk about these things will be the notion that glaucoma management may become depersonalized. So that whereas in the past, you may have had a very good one-to-one relationship with a consultant who saw you at every visit. And then if we were to enact these changes, you may well find either that you're not seeing a consultant at all because you're just coming in and having tests done, and then at the end of the day, you just get a generic letter to tell you whether you're stable or whether you need a change of treatment afterwards. Or when you're coming for a face-to-face appointment, what's now happening at Moorfields is that we no longer run named consultant clinics. We actually have pooled clinics where all the patients are seen by a team of consultants. So we will have 3 or 4 consultants in the clinic, and they all manage the patients together. And the reason for doing this is because we are now seeing a much more distilled and concentrated mix of complex patients who need consultant-led decision making. And so having the clinic filled with more inexperienced people will just slow down that process. So we're trying to ensure that, as I said before, the right patient is seen by the right person in the right setting. So the hospital setting should be for the really, really very glaucoma patients that are in trouble and need to have a face-to-face consultation or need to have an important conversation. Whereas for the more routine stuff, rather than having a 3-hour appointment, you can have all your tests done in 45 minutes and you're out the door, and you're minimizing your risk of viral transfer on the assumption that this COVID situation will be around for the foreseeable future. I'm going to wrap up because I can see there are some questions stacking up, but I'm going to wrap up very, very quickly here. I just want to reassure you all that we are very aware in ophthalmology that one of the unintended consequences of the coronavirus pandemic is the fact that ophthalmology has gone to sort of the back of the queue because it's not a life-threatening condition. But glaucoma has such a serious impact on people's lives if it is not appropriately managed, that we are taking it very, very seriously in the ophthalmology community, and we are going to do our very, very best to ensure that we have robust and safe processes that ensure that regardless of whether there's a second or a third wave, that we have got the facilities to continue to provide first-rate ophthalmology care for patients who are at risk of losing their eyesight from glaucoma and from other diseases. So, we were a little bit caught on the hoof and had to make quite drastic changes when the virus first hit. But I think we will hopefully end up in a much better place, because a lot of the things that I've been talking about are things that we were talking about theoretically for 4 or 5 years time, that we will make incremental changes to make our services better. But of course, the pandemic has changed all that. What it means is that everything now has to be done on steroids, and we have to make these changes and make them stick fast. So I'm genuinely optimistic that glaucoma services will improve as a direct response to dealing with the problems caused by the pandemic. But I must say, knowing that there are any number of hundreds of thousands of glaucoma appointments that have been deferred across the country, it is going to be a daunting challenge. So I'll stop there, and I think Jo will curate and steward any questions.
Yeah, great. Thank you so much, Nick. If I could just ask you quickly to try and hold your phone a bit stiller. There's while you're gesturing, there's a bit of movement. That's fine.
Sorry.
That's fine. Don't worry about it. It's still enthusiasm coming across. First question we had was obviously lots of conditions are being managed remotely, so that not via face-to-face consultations. And so, how well do you think glaucoma can be assessed, sort of other than by face-to-face? Can it be done remotely?
So certainly this is something we have looked at in great detail at Moorfields, because we virtual clinics are not a new thing and remote care is not a new thing. But at Moorfields, because we are the biggest provider, when we do adopt something, we test it to the nth degree, because we're going to be doing it at scale. So we want to make sure that what we're doing is robust. And we have audited this to there's a continuous audit and quality and safety measures that we're looking at. And what you have to remember is that when you go to an outpatient appointment, the likelihood of you seeing a consultant glaucoma specialist in your clinic, wherever you are in the country, is actually relatively low. It might be 1 in 3, it may be 1 in 5, it may be 0. What I tend to hear often in my private practice, because I see a lot of people who come for second opinions, is that they are frustrated with what happens in their outpatient appointment, because they see a different locum doctor every time. And of course, to manage the large number of patients, what a lot of hospitals will do is they will just bring in locum doctors who are not necessarily glaucoma specialists, not necessarily that well versed in glaucoma management, to get through the number of patients that need to be seen. And that was actually something that was highlighted in the HSIB report about visual loss from glaucoma, that inconsistency and lack of training of the doctor that's been drafted in to look after glaucoma patients was a contributing factor. The difference is with a remote care or a virtual clinic, as done in the Moorfields way, you are having tests done that you don't necessarily have every time. So most of you will not have a visual field test every time you come to the clinic. You will probably have one done a year. If the evidence suggests that you actually, in order to pick up glaucoma progression, you probably need to have 2 or 3 a year. But most people, the average in the UK is about 1 a year. So you have more tests done than you would do normally, and you will have your tests reviewed by a glaucoma consultant. So you are automatically having the most senior opinion and the most available evidence. Where it falls down is that you are not necessarily able to have a face-to-face conversation about something that is complex, but there are fail-safes there and red flags that the technicians have in terms of their questionnaires, whereby if there is a problem and it's alerted, they know how to get the patient seen in the clinic either that day or urgently or soon or whatever. So it is safe, and we haven't had any, I'll put it in another context in terms of the safety. The alternative to not having these clinics is not seeing these patients, or seeing them at the wrong interval, or getting them seen by the wrong type of person. So it's a safer option because it's actually creating a safe structure by which patients can be seen in a timely fashion. So if you didn't have it, more patients would be at risk of losing vision.
Yeah, thanks. I think the question was a bit more about, can you do it from home? So could you do?
Oh, I see. Okay, yeah. Okay, I see.
So pressure tests at home.
Yeah. So the problem with just relying on a pressure test is that it doesn't actually tell you very much about glaucoma. It will tell you whether the drop you are using is numerically getting the pressure down to a level where you think it should be, but it won't be telling you whether the glaucoma is getting worse or not. So in reality, the one thing, if I was going to pick one test and one test only that actually would be of benefit, and you're all going to hate me for saying this because it's going to be your least favorite test, the one that gives you the most information, that actually tells me whether or not you're any risk of going blind in your lifetime, is your visual field. Okay, so the thing is with visual fields is that you all know that, if those of you who've been coming to the clinics for a long time will know that that bloody machine hasn't got any better or any quicker or any easier over the last 20 years. And people have been trying to develop things that will run on a laptop or run on a TV screen or on an iPhone. And there probably will be better ways of doing a visual field test. But until such point as we can do home monitoring of the visual fields, and things are on trial, and the Glaucoma UK is funding one particular project on a device called, on a program called Eye Catcher. So, you know, watch this space, things may come online. But you know, without having those tests available, there's limited information with just, you know, the home eye care monitoring system. I mean, I have patients who have got those things, and it's I think it's unfortunately what tends to happen is that patients buy them because they're already a little bit obsessed about their pressure, and so they go to a point where they're checking it every hour. And so it becomes part of either a reinforcement making them feel better that their pressure is well controlled, but it may be a false impression. And secondly, or that it will make them more anxious if there's a deviation and want to be seen straight away.
So there is a question there about, is there any chance of home tonometers enabling patients to manage glaucoma more effectively? Sounds like you're a bit skeptical about.
No, I think one of the things that the government is very keen on, and something that we are optimistic that will help in ophthalmology, but maybe glaucoma is a bit more difficult, is self-directed care. So whereby for some chronic conditions, patients will be aware of changes that would allow them to initiate their own appointment, rather than them having a routine appointment every 6 months, whereby they could actually extend it for longer if they knew they were fine. Now, the problem is with the pressure, that's just one metric. And if you had the ability to, on your iPhone, say, have an OCT device or an ability to photograph your optic disc and also do a visual field test, that may be a way of self-monitoring and feeding that to the hospital. But in all honesty, you could get around these things, either in some communities having these tests done at a local optometrist and having them conveyed by telemedicine to the consultant at the base hospital, or going once a year to a diagnostic hub of the kind I described and getting it done there. But the technology is not quite there yet to really safely do home monitoring for glaucoma, I would say.
Yeah, I suppose it's a bit like obsessing with, you know, to use an area that people are more familiar with, obsessing with your weight. So thinking that you weigh 65 kilos or 75 kilos or whatever it is, and that's just one measure of your sort of your health.
Yeah, I suppose. I mean, I think, I mean, a lot of people do have blood pressure monitoring devices at home, and now blood pressure is very, very clearly linked to a number of disease endpoints, like risk of heart attack, risk of stroke, risk of ischemic heart disease. And so being able to monitor your blood pressure, particularly when you're on treatment, is useful, because there is a clear relationship between your blood pressure and your risk of these diseases. When you are, there's two problems with home IOP monitoring. Is number one, it's not necessarily that accurate, because there's a user error, because you're doing it on yourself, which is quite weird. And secondly, the rebound tonometer is not the most accurate way of measuring the pressure. Okay, so there will be a margin of measurement error, both from the user and both from the technique. And then whether your pressure is 16 or 19, without monitoring over time and looking at the visual field and looking at the optics, you can't say whether that's actually important. Mm-hmm. So it's hard for, you know, if you did a one-off reading and it was 40, you would be concerned and go straight to the hospital. But other than that, for regular monitoring, I'm not sure how useful it will be.
Yeah, great, thank you. So we've had quite a few questions about the role of optometrists in this. So I wonder whether you could just talk a little bit more about the sort of normal journey for people from sort of referral from an optometrist into hospitals, and then how you think that might change because of COVID.
Sure. So I can only really talk about the pathways that I sort of have where I work, but there are things will be different in different areas of the UK. So for myself and what happens at Moorfields, it's a very conventional thing. So you as a patient will go to an optometrist for an eye test, or you may go because you're concerned about your vision. They will pick up some features that make them suspicious of glaucoma, whether it's high pressure, suspicious disc, or something on the visual field. They will write a GOS 18 to the GP. The GP won't necessarily understand that, but then they will use that to refer to the hospital to say this patient might have glaucoma. The patient will then get an appointment in the outpatients, and then you are normally, certainly in Moorfields, you'll be managed in the outpatient setting of the hospital. Now, there are alternatives to this. Now, some commissioning regions will have a system of referral refinement. So the optometrist, if they're concerned about glaucoma, will send you on to a commissioned optometry practice or group of optometry practices where additional testing can be done to further whittle down the likelihood of glaucoma. And then further to that, they may either refer you on to the hospital for management there, or they may be in a position, if they are commissioned to do so, to manage the simple and lower risk glaucoma themselves, and some may be able to prescribe, etc., etc. Now, the thing is, the COVID pandemic has been really hard on optometrists. Optometrists are primarily businesses, not primary care providers. So they are in the business of selling glasses and secondarily gaining income from providing additional health services. And the pandemic has been very, very unhelpful for them in the world of selling glasses. So particularly the large multiples have struggled financially over the last 4 or 5 months. And even now, with lockdown being restricted, they're not yet seeing the same volume of patients as they or clients as they would have done, because they can't process as many patients as they would have done pre-lockdown. So I am not yet sure, particularly for the big multiples, what their own appetite will be for managing glaucoma services large scale. Prior to lockdown, I think it was fair to say that large multiple optometric practices were looking to get commissioned to do large amounts of routine glaucoma work, because it was steady income and it was relatively low risk, and the commissioners, they could potentially provide that service cheaper than the hospital could. So in other parts of the UK, that is already the case. But certainly in London, the commissioning environment has changed a lot. They are less inclined to commission services to private providers, and also the funding is via a block contract rather than payment by pay as you go, if you like. And so the financial incentive for an optometrist to take on commissioned glaucoma at the moment in the COVID pandemic is much less. I mean, they will lose money rather than make money.
Right. So it sounds like a nice idea, but it won't actually. Sounds like a
No,
solution.
I think so. I think, in all honesty, it would depend on which part of the country you're in. If you are in an area where the hospital cannot cope with the burden of glaucoma care, the people that commission the services may look and say, well, you are failing, but here is an optometric provider that has got lots of practices with lots of equipment and lots of appropriately trained staff who can manage it, and may divert the services to there. Or, and this has been done successfully in a number of regions, that you may have some very, very excellent optometrists in the community who are able to work closely with their hospital colleagues and co-manage. But it's going to be very hard to co-manage 200,000 outpatient appointments, if you see what I mean. So a distributed care model where you'll have 5 or 6 patients a day being seen in an individual high street practice is not going to get through the backlog of patients that have been. And so that's why, you know, and I hate to use this word, the sort of industrialization of routine glaucoma care might need to be done to safely get through the backlog.
Okay, and just on that, in terms of the do you have a feel of what's happening in kind of, you know, district general hospitals or centres? You know, you're obviously talking at that kind of, you know, the Moorfields end, which is the big tertiary centre. What sort of, how are things different broadly in the kind of smaller hospitals? Do you know? Do you have a feel for that?
So Joe, to clarify though, I mean, I think, you know, whilst Moorfields is a tertiary and quaternary centre, the bulk of what we do is secondary care. Right. So the bulk of what we do is providing ophthalmic services in and around London for routine stuff. So we are essentially doing the same thing as the other DGHs are. So just to clarify that, so it's not just the weird and wonderful stuff that we do. It's the bulk of what we do is the routine stuff. I think in the district generals within London, it has been very, very hard. We are located in a number of these places. So we provide the service at Croydon, we provide the service at Northwood Park, we provide the service at Ealing, and we have operating theatres in those sites. And of course, because of COVID, we haven't been able to use those operating theatres. So there are a large number of cataracts, and there are a large number of glaucoma surgeries that we're not able to do locally. So we're having to bring patients to the main central hospital in order to do their surgery. And of course, some of the estate where we would have been seeing glaucoma patients has been taken over by COVID, although it's a red area for known COVID patients. And I think that's happened in a number of district general settings around London. Of course, COVID has not been as impactful all around the country. For example, in the southwest of England, it's pre, you know, COVID clear, and then you've got areas like Oldham and Leicester where they're having major flare-ups. So it'll vary from region to region. But what is clear is where there is a big flare-up, the way hospitals work is that all hands will be on deck to address the elephant in the room, which is not going to be the backlog of glaucoma patients. It's going to be the patients who are at risk of dying from COVID and the people that are at immediate risk of death because their care is being deferred or displaced because of COVID. So I think that's the problem. And what we have to do as the health system matures to understand how to deal with COVID is that we have to get to the point where whether or not there's a spike in COVID or whether or not there's a second wave, that we don't shut down our services because we've got all the mitigations to cope with it. So no one is shortchanged or misses an appointment or goes blind because of this other thing that's happening, because we need to have learned the lessons of how to deal with it.
Okay, great. Yeah, thank you. And how much is, another question is the ophthalmology community working together? So, you know, stuff that's been learned in hospitals, you're sort of sharing in other hospitals across the UK and across the different nations?
So in terms of from a London perspective, there is quite a lot of teamwork happening. So in each, London is divided up into 5 STPs, and in each STP, this is the commissioning body for medical services. In each STP, a lead ophthalmology provider has been appointed, and that lead provider has to work in partnership with the other providers in the patch to optimize pathways and ensure, you know, we work together to get through the shared problems of COVID, particularly in terms of elective care, of which outpatient glaucoma stuff is part of. So with that, there is that. Secondly, most of the major ophthalmology units across the UK contribute to a weekly national leadership call coordinated by the Royal College, which where we discuss this stuff. So I know, my opposite number in Manchester is always bugging me about what we're doing, so that he knows, he has a feel that he can go back to his management team and explain things. This is what Moorfields are doing, and there has been a NHS EI, so that's NHS England, NHS Improvement, have appointed 3 individuals who are tasked with outpatient transformation for ophthalmology. So this is a government NHS level leadership role to talk about, to basically roll out everything I'm talking about. And that has an ophthalmologist on it, which is Melanie Hingarani, who's one of my consultant colleagues at Moorfields. But there's also an optometrist and a nurse on that body. So it will be integrating the wider eye care community, including optometrists.
Great, thank you, lovely. So in terms of the kind of treatment that people might have, there's been a lot of conversation about the sort of appointments, but that sort of normal glaucoma pathway of, you might get put on drops or maybe laser first, and then sort of that, drops you might have your drops changed, and then you might go for surgery if it's getting worse. How do you think that might change, particularly in the light of, say, the laser, so the light trial that's kind of shifting people more to laser, or the management of eye drops?
Sure. So the evidence would suggest that SLT laser would be the preferred first-line treatment for primary open-angle glaucoma, and certainly in our practice, it has had a major shift. So more patients are being offered that. And I think it is from a COVID perspective, is a better option, because it requires fewer outpatient appointments, and it would probably require fewer interventions in the first 3 years of follow-up. And so, if the option was to keep tinkering with drops, or have an SLT at 1 year and 3 years and at 5 years, doing SLTs and repeating them would probably be a better option than having the drops. But of course, not every patient wants to have laser, and not every patient is suitable for laser. So that you can't have that blanket application of rules. But the other thing that we have instigated at Moorfields, which we never had before, is the ability to, previously where we had the virtual clinics, if you wanted to instigate treatment, so start someone on drops or list them for laser, you would have to bring them into the hospital to do that. Whereas now, what we are able to do is we can write to the patient, say, we are sending you a prescription, or our pharmacy will actually send the drops to say, this is what you need to take, and send the drops. So you are, the key thing is actually to minimize the number of unnecessary hospital visits. That's been absolutely key in COVID. And the one thing glaucoma specialists love is unnecessary hospital appointments. So we're having to we're having to modify that. The surgical side of things, from our end at Moorfields, what we're finding is that we're doing a hell of a lot more surgery, primarily because of the backlog. Unfortunately, there are a proportion of people who, with complex disease, so people who've got corneal problems or retinal problems, etc., who did not come straight away to the emergency room because they were shielding, or because they didn't want to come to the hospital. And so there are some patients who have presented later than they would have done ordinarily. So they're going rapidly to surgery, rather than it being a gradual process for them to go to surgery. So, what we're finding is that when we're offering patients surgery, 50% turn us down, and 50% turn us down even if they know that deferring will cause them to lose vision.
Do you think that people, does the type of surgery matter? So is there more enthusiasm for things like MIGS, minimally invasive surgery, versus trabeculectomies, or are they different audiences anyway?
No, I think the thing is, for most of us who have a mature surgical practice and have people who are genuinely going blind from glaucoma, we tend not to have, we wouldn't discuss MIGS as an option. It would be trabeculectomy or tube surgery, or possibly a micro shunt. The MIGS stuff is really concurrent with cataract surgery, and for most centres, cataract surgery is sort of the last thing that's coming online. I mean, I did a phaco MIGS on someone yesterday, but it's the first one I've done in 5 months. So no is the answer at the moment.
Yeah, that's fine. And so there's just to read this question specifically, we've got 5 minutes left. How is the queuing time for glaucoma surgery in the NHS? So it's probably taking longer, but presumably the ones who might need surgery are the ones that you're kind of pulling back sooner. They're going to be top of your list, or as long as
so at the moment, I mean, I can't speak about other hospitals, but at Moorfields, what we're doing is we are most people that require glaucoma surgery technically fall into what's called a priority 1 or priority 2 level of urgency. So we've been, as soon as we were allowed to do priority 2s, so priority 1s, the ones that if you don't do the surgery, they will go blind in the next 48 hours. Mm-hmm. So obviously we did all those cases. And when we got to the priority 2, those are the ones that are patients who, if you don't do the surgery, they're going to irreversibly lose some vision in the next 3 or 4 months. Those are the ones that we're doing. So essentially for the last 6 weeks, we've been doing 4 glaucoma operating lists every day for 5 days a week. So we have really got through the backlog. Mm-hmm. However, with 50% of patients not wanting to come in. So we're having to go back through the list and ask people again if they're prepared to come in. And the problem, the reason why people don't want to come in is manifold. One is because, if you're elderly, you don't want to come into a hospital for fear of COVID, and you may put your personal risk of COVID as being more disconcerting than the potential of losing some vision by deferring surgery. But also, up until very, very recently, we were firstly 14 days of household isolation with a antigen nasal swab at 3 days beforehand. So full household isolation for 14 days. For most people, that's, if you can put it off, you'd put it off. Now, then it became 7 days. New guidance that came out yesterday is going to be 3 days. So, it's getting easier and easier, mm-hmm. But whether or not it's prudent to not have these measures in place is another matter. I know that there are some ophthalmology providers who are basically not isolating and not doing any testing at all. I totally disagree with that, but I'm not I'm not the medical director of a private company providing high volume cataract surgery.
Yeah, that's true. Well, I think this is last couple of questions. So, do you think the role of eye clinic liaison officers could be built into the transfer of some services from tertiary care to the high street? So, could ECLOs help in that?
I mean, I think ECLOs are incredibly important. In terms of just that interface between the reality of living with an eye problem and the somewhat more mechanical process of coming and having your pressure checked and seeing the consultant and getting a pat on the head, being told everything is fine. There probably aren't enough ECLOs out there. There may not be enough doctors and optometrists who manage glaucoma that know that they can access the expertise of an ECLO. And of course, patients don't necessarily know that such an individual exists. So they're a relatively rare commodity, but they're worth their weight in gold. So I think any expansion of that role, any wider scope where they can use their expertise to support patients is something that I think would be of great benefit.
Mm-hmm. Yeah, but we just need more of them.
More of them and more spread about.
Yeah, great. Right, I'll just do one more question. What I'm going to do quickly is to just do a new poll to sort of see how much everyone's learnt from this session. But we'll do one more question just as we hit 8 o'clock. which is, are optometrists' visual fields of a good enough standard compared to hospital ones to use as part of overall care? Is there a difference in the standard?
So it really depends on which optometry practice you go to. So the vast majority of optometrists, when they do their visual field test, will do, because they're trying to process patients very, very quickly, they will use a screening test, and those screening tests are very, very quick. And you'll notice that they make a very different printout from the type that you have at the hospital. Those are not reliable for monitoring glaucoma or for diagnosing glaucoma, actually. Quite a lot of optometrists, particularly the higher end optometry practices and the ones where it is an individual optometrist practice rather than a multiple, may well have the same equipment that they have in the hospital. And where they have that, then of course if the optometrist is appropriately qualified, they may be able to manage routine glaucoma themselves if the service is commissioned to them. So in some cases, yes, they will have the right visual field equipment. In a lot of cases, no.
Okay, great, thank you. Right, well, time's up. It's 8 o'clock. I'm aware that I haven't answered all of your questions, so I'm well, asked them all to Nick. So I'm really sorry about that. If your question hasn't been answered, you can sort of contact the helpline on helpline@glaucoma.uk, send your question through, and we'll try and sort of give you a more detailed answer. So I'm very sorry if your question hasn't been answered tonight. We've run out of time, but I'd like to thank Nick for a really interesting talk about a very complicated situation. So thank you very much for your time. We've really appreciated it. And thank you everyone for attending. I hope you've enjoyed it. And as we finish, there'll be a survey that comes up, and you'll get a reminder email tomorrow. These sessions are new for us, so the feedback and evaluation is really, really important. So we'd be very grateful if you could spare the time to do the survey at some point. Thank you very much, and thank you, Nick. Right, good night.
Bye. Thank you, everyone.